Good morning, everyone. I'm Robin Shapiro. I'm the board chair of HealthAdvocateX, and I'm delighted to be here to talk a little bit about Ozempic and some of the products that are similar to Ozempic. We have with us today Dr. Samatha Pabich, who is a MD, MPH, and a Wisconsin-based endocrinologist, obesity medicine specialist. I've really enjoyed speaking to her as we've prepped for this call. There's so many interesting things related to this topic. So, as we usually do, she'll be giving us a bit of a presentation for 10 to 15 minutes or so. Please put your comments in the chat and your questions, and I'll be going ahead and asking her the questions as we go along in this community conversation. Dr. Pavik?
Hi, thank you so much for having me today. It's delightful to be here. Coming to you from Ho Chunk land. Um, and uh, yeah, I'll get started by talking about the fact that the medicines I'm going to talk about are approved for use for diabetes and obesity. But to start off with kind of a sense of what is obesity, because that I think has previously been a word that has been assigned a lot of blame. So I was talking to Robin, and I was talking about how these medicines are helping us take awareness that it's not necessarily our frontal lobe, the part of our body that is what does our thinking, that makes us human, that is driving our appetite. It's actually our hypothalamus. This is like a conserved structure from evolution. I tell patients it's part of our lizard brain. It's the part of the brain that says, like, if you do not eat, you will die. And it seeks the food any way it can get it. And some people have overactive hypothalamuses, and some people have had history of things that have happened to their body that have made their hypothalamus be a little bit more worried than average about the possibility of famine and starvation and food scarcity. And so, whereas in the past, your doctor was probably somebody who said, hey, you should just work harder at your weight, eat less, exercise more, do better. And people might have had a good intention with that kind of advice, but it turns out it's not our human brain that is necessarily governing our calorie balance and our stored calorie balance. And so taking a minute to acknowledge that it's something that is different for all people, and it's not a reflection of how hard you work or how hard you try. And that's why these new medicines can be really, really helpful, because for somebody who has tried really hard, who has put in all the work and has had their body just say, hey, I'm adapted to survive famine and starvation, and I'm not going to give up any of this stored calories. Now we have a medicine that can be helpful. We have a class of medicines. So I'll switch into talking about these medicines, which are called GLP-1 agonists. And they're a class of medications that stimulate receptors in the brain and the gut. They increase fullness, they help the body respond to sugar, and they slow down the movement of the gut. So the first med in the class was approved in 2005 for diabetes. And since then, there have been about 4 or 5 more drugs that have come out in the class. And the FDA has approved them for diabetes, but also the treatment of obesity, and also the prevention of heart attacks or strokes in people who have had prior vascular events. So the names of the meds that are most commonly used in the United States are liraglutide. This goes by the brand name Victoza if it's treatment for diabetes, or Saxenda if it's treatment for obesity. There's dulaglutide, which is Trulicity, a treatment for diabetes. There's semaglutide, which is Ozempic for diabetes, and if it's being used for obesity, it's called Wegovy. And then there's tirzepatide, which is Mounjaro for diabetes, and Zepbound for obesity. And these generic medicines are exactly the same medicine, but they've just been marketed for different purposes. So when you see the diabetes version or the obesity version, they're the same medicines. Only one of these is a generic so far. Liraglutide actually just came off of patent in June. And so there is currently one company that's making a generic, but all of the other ones are still on patent. And there are some pharmacies in the United States that are selling these compounded forms of the medications. And so these are not regulated by the FDA, but they're intermittently legal based on a patent law loophole that allows compounding pharmacies to help make up supply if the patent holders can't keep up with demand. So there's a statement about this on the FDA website, and essentially, if the drug is listed on an FDA shortage list, then it's legal for a compounding pharmacy to make it. But it's been really confusing for patients because these are being advertised as much less expensive than the branded medicines. They are not as regulated, and so with using them, I think that there's more risk in using them. But I can answer more questions about that later on. So in trials of these medicines, we all had really hoped, like, let's have people start these medicines, make changes to the foods that they eat, help kind of get in a habit of eating healthy foods, maybe lose a little weight that makes exercise a little bit more comfortable, then they can start exercising, and we'll be able to have them come off of the medications. So they did this in the trials, even though the pharmaceutical companies really don't want somebody to be able to come off these medications, but they tried it. I give them credit for at least trying it. So in the step 4 trial at week 20, they had their whole group of people who were on the medication, and they switched half of them to a placebo. And what we saw is that within 1 and 2 weeks, people were already regaining the weight. And so it's, as much as I want it to be one way, that if you make your lifestyle changes, you'll be able to maintain the weight, that's just not what the evidence shows us. And I think that's where we need to be moving in terms of obesity medicine. We need to look at what the data shows and follow that. The reason that we think these that this weight regain might be happening is, first of all, the difference between maintaining weight and gaining weight can be as little, in some studies reported, at 93 calories per day, which is an amount that's so small that our frontal lobe honestly can't even perceive it unless you are weighing every single thing that goes into your mouth and never varying from that. It's really, really kind of almost impossible to be aware. This is like 2 or 3 spoonfuls of food at any given meal. And then the other thing is that when people stop this medication, when my patients aren't able to access it, they tell me, I notice my hunger. Hunger is the thing that is my biggest predictor that weight regain is going to be happening, because once the hunger comes back, little bits of extra food they're gonna find their way into your diet. When people are feeling hungry, they are maybe unintentionally, maybe unawaredly having a little bit of extra food. And sometimes it might be aware. It might be, I was feeling starving all day long, and I finally had to cave at the end of the day. And these medicines, one of the best things about them is they take away that feeling, and then they take away the associated guilt, because you just don't have the hunger. So therefore, it does make sense that we use these medicines continuously and long-term, because they're modulating our hunger on a day-to-day basis. And I wish it wasn't the case, but it is. There are several side effects to these medications. Most of them are GI related. I tell my patients, it's a literal crapshoot. Some people get diarrhea, some people get constipation, and then you can also get nausea, vomiting, abdominal pain. Anything can happen. And it's kind of hard to predict what will happen to what person, but the side effects are reported at affecting anywhere between like 5 and 40% of people, depending on what drug it is. So some people will take one dose, and I say, they'll say, curses, Dr. Pabich, how dare you have prescribed this to me? This is the most miserable drug I've ever taken, and I will never take another dose. And that's okay. Those people they might be in for a rough week, because these medicines kind of last in your system for about a week. And it's a risk that anybody takes when they're taking this medicine. But we start them at a very low dose with the idea that the first dose that you start at hopefully won't even have that much clinical significance. It's just giving your body a chance to get used to the medicine. And then I tell my patients, you should go up only when you're feeling good. And if you're able to, you're a little bit queasy, you're not having the most pleasant day, but you're able to tolerate it, the next time you take a dose, it theoretically gets better. And a lot of my patients have gotten used to these, reporting that by 4 to 6 months on the medicine, they feel completely normal with no GI side effects. There are some more rare side effects. So in rat studies, these medicines were associated with an increased risk of a very rare type of thyroid cancer. And I like to tell people about this because papillary thyroid cancer is really common. And so a lot of people have had a relative who had that. We tend to look at thyroid nodules and kind of make sure that they're not that. This type of thyroid cancer is super rare. It's not a reason that most people can't take this medicine. So even if you're nervous about it, talk to your doctor. It's probably still a reasonable medicine. Pancreatitis is a side effect where you get inflammation of the pancreas. It came out in one of the earliest studies that maybe there was an increased risk of pancreatitis. And so after that point, they stopped including anybody in the trials who had pancreatitis. So now when we look back at the data, we don't actually think these medicines increase the risk of pancreatitis, but we are like very cautious, and these people have not been included in trials, and so it's still kind of considered a reason to avoid the medicine, and if you have it, it's sometimes a reason to stop the medicine. And then the other side effect that I kind of have seen a little bit more are just consequences of dehydration. So somebody might have a lot of vomiting, a lot of diarrhea, they get a little dehydrated. It can cause a kidney injury. It can cause lightheadedness or fainting. Those are all things that are important for a patient to recognize early, and then you can seek treatment. If you can't keep water down, you can go get some IV fluids. So it's like having that knowledge ahead of time can help you do the right thing for your body.
Does the drug affect your interest in also drinking enough water? Because it
It
seems
does.
okay.
Yep. So people do have decreased thirst on this medication.
Interesting. So you
Mm-hmm.
have to really be cognizant
You have
of
to be
that.
aware of it. Yep.
Hmm.
This is
Hmm.
where those big Stanley water bottles come in handy, most of the time. I don't think that they're medically helpful, but in these cases, they probably are. Gentle sips throughout the day. And then also, as people lose fat, you inevitably lose muscle. And this happens with any type of weight loss, but it's something that as more and more people are using these medicines, we're trying to provide people with excellent information. It's important to work your muscles and to continue doing resistance training while on this, because your body, it's not carrying around as much weight as it used to. You don't have to move as much weight, and so your muscles will get smaller in that case. And so it's a good idea to keep that up. I also tell people you still need to nourish your body. There are times when I have a patient who says I just ate 2 crackers yesterday, and you know what, that might allow for weight loss, but that's not a good way to live. You've got essential nutrients that you need. You need proteins, heart healthy fats, vitamins, minerals, fiber. And if you're not getting those in a typical day, it's time to consider cutting back on your dose so that you're able to get the nutrients. If we could all just stop eating, then dealing with obesity wouldn't be so hard. But we need to continue eating.
Mm-hmm.
So people put up with these potential side effects because of potential profound benefits. So when I was using these medicines just in the beginning for diabetes, we were seeing average blood sugar point drops of like 30 to 60 points, 2 A1C points, sometimes 3 A1C points. A lot of patients on the newer medicines are able to get off of insulin if they previously required insulin. Not everybody, but it's a cool thing when it happens. The newer semaglutide and tirzepatide boast weight loss of 15 to 20%. And then the semaglutide, as of a study that came out in December, the SELECT trial, showed that it reduces the risk of having a second heart attack or a heart event by about 20%. So
Wow.
really, really exciting stuff. There's more and more data coming out every day. So people are having improvements in sleep apnea, sometimes being able to get off CPAP. People are having improvements in liver disease. And this is making us think, like, are we going to help people avoid liver transplant?
So why would that happen?
Because the fatty liver disease is
Okay.
the biggest cause of liver transplant.
Mm-hmm.
And as these drugs help you lose fat, it's ideal. It's our favorite when the fat comes out of the visceral compartment, the area around your organs, because that's where it's most metabolically dangerous.
Yeah. So when you're losing the weight, is it specifically targeting the fat more than muscle, or just everything's being reduced because you're losing weight?
Um, Most of the time, if your body isn't getting enough calories to meet its daily needs, it's preferentially going to be breaking down fat for stored calories. But and so I'm not sure it definitely can also break down muscle to use for calories, and I'm not sure how much that is happening. versus how much of the muscle atrophy is due to the fact that the muscles aren't being used as much.
Mm-hmm. Yeah, because I think that's the Ozempic face and Ozempic butt that we've
Yes.
seen. So everybody's seen a little bit about that.
People have seen it. Yep. You
Yeah.
get the loss of the subcutaneous fat on the face and some appearance of wrinkles, but sometimes people will take that if it can prevent a heart attack.
Yeah, yeah, amazing, amazing. And can you tell us a little bit about kind of what is happening specifically in the gut when you take these medicines? So break that down to us pretty simply in terms of the motility and that kind of thing.
So there are GLP-1 receptors that are located throughout the gut. Um, the idea of an agonist is something that binds to a receptor and turns it on. And as I understand it, I would say, like, I don't have the perfect understanding of the physiology, but basically it's something that is anti-motility. It kind of slows things down. Other places where GLP-1 is expressed is in the pancreas, and so it prevents release of glucagon, which raises the blood sugar. It's also expressed in the stomach, and so at each of these places, it's working, I think, overall to slow things down. When people have that increased feeling of stretch in the stomach, that's something that then sends a signal to your brain that it's not hungry because the stomach is stretched.
Got it. Yeah, so interesting. Wow. Um, and so in terms of taking these drugs forever, can you talk a little bit about kind of some of the pros and cons of that over time and what your experience has been with your patients?
Yeah, so I've been using these medicines since 2014. And so I feel like I personally have seen people who have been on these like for 10 years. Um, what I can say is that there are some people who I would look at and I would say, "Oh wow, your risk of having a heart attack in the next 5 years is pretty high. Your risk of having a major dangerous stroke in the next 5 or 10 years," and we can actually calculate that with the ASCVD calculator. We can calculate how high someone's risk is of having a heart attack or a stroke. And so to say this medicine might be dangerous and it might have some side effect that appears in 20 years because we haven't really been using them quite that long
Right.
is to balance what we know is happening within 2 or 3 years, that we're reducing this risk of having a heart attack that might be this person's most impending problem.
Mm-hmm.
And
Yeah.
that's how I'm thinking about it. I think that for a young healthy person who maybe only has obesity and they don't have any complications related to the obesity yet, um, there might be a little bit more when I'm weighing my benefits and my risks. The risks might be a little bit higher for that patient because there's not that many benefits to balance it out. Whereas for
Mm-hmm.
a person who's got high cholesterol, high blood pressure, high blood sugar, we can tell already, even in 2 or 3 years, that we are saving lives, prolonging
So
lives.
yeah, yeah. So we have a question. Thank you, Michael Wood. Given the overwhelming consumption of ultra-processed foods by Americans, how does that factor into long-term use of GLP-1s? Like over time, if your diet is still poor, I mean, you were talking a little bit about that before, but yeah.
Yeah. I think it's hopefully not any poorer than it would have been. And that's kind of how I've rationalized this to myself. If somebody is um, not able to choose the foods that I think are the most high quality or the most healthful, if at least they're not choosing foods that are worse on this medicine, then hopefully the physiology of having less adipose is still going to be a benefit to them, even if they're not getting great nutrition.
Mhm.
Um, I encourage my patients to focus on having um, like heart healthy proteins and heart healthy fats and lots of vegetables. But you know that not everybody is going to be able to do that either because they choose not to or because of reduced access to healthy foods,
Mhm.
affordability, knowledge. And so I kind of put it in two different boxes. There's the box that's thinking about someone's adiposity and the box that's thinking about their nutrition. And we can
Mhm.
try and improve both.
Mhm. And adiposity meaning fat.
Yes.
Okay. Just wanted to
And
make sure
Dr.
for,
Pavich,
yeah.
to follow up on that, is there any, I mean, it's your requirement to decide whether to prescribe or not, but are there guidelines about what you should try before? I mean, is there a standard of practice around that?
Well, so there is, in terms of the guidelines for management of obesity, right now, the national societies still recommend that somebody make lifestyle changes before they try a medicine. And I think that makes sense because if the lifestyle changes work, like then maybe somebody doesn't need a medicine. But we know that when people try, like work really hard, do a high intensity lifestyle change program for, 3 to 6 months, they typically lose between 5 and 10% of their body weight and often regain about 80% of that by 5 years later. So we know it's unlikely that people are going to have enormous amounts of success with just lifestyle change. But I tell my patients, if you're the one person who does that, that's fantastic. So for obesity, you are supposed to do lifestyle changes first and then add on a medication if you didn't get to your goal. Interestingly, though, that requirement doesn't exist for the diabetes medicines. And so when I prescribe the same medicines for my patients with diabetes, all of a sudden they come back and they say, "Hey, doc, I'm not so hungry anymore. I'm not turning into McDonald's every day anymore because I just don't feel hungry." And so I say, "So you make it all the way home and you make dinner at home?" They say, "Yeah, I didn't have to make that turn." And so it's like an organic improvement in their diet that happens because of the lack of hunger. They say, "You know what? I really wasn't listening to you before when you were talking about doing that daily walk because my knee pain was too bad. But now I've lost 50 pounds. My knees don't hurt anymore. And now I'm going walking with my dog every day. My dog's never been happier." And so it's like, it's almost a paternalistic statement to say that your patient has to make lifestyle changes before we help them, because we know now that if we help them, they might be able to make lifestyle changes.
So we're getting some more comments in the chat, which I'd like to have you answer. One is from Claire Morley, who said that some people are taking PO instead of injectable, and is this route as effective?
Yeah, so PO means orally, it's a pill. And so there's an oral version of semaglutide that is not as effective as the injectable version. People tend to lose about half as much weight, around 6 to 7%, on that oral form versus like 15% with the injectable form at max dose.
Interesting. And Heidi Coomer says there's a significant amount of obesity, diabetes, prediabetes, and fatty liver in the Hispanic population. And many of them are on some form of Medicaid, but it seems impossible to get access to even metformin, not to mention liraglutide. Have there been any studies looking at minority populations?
Um, so I can't speak offhand to studies that specifically like looked at minority populations, although the data in all of the like major drug trials does report weight loss, or they report the percent of minorities that were enrolled in the trial. At least one study that I looked at didn't see differential weight loss in like several races that were enrolled in a trial. But I don't know about every single study that's been conducted.
Yeah.
In my state, Medicaid does cover these medicines, but that's going to be different from state to state. And what I'm hoping will happen is that in time, I'm hoping that big purchase power can negotiate down the price of these drugs. Semaglutide's due to come off of patent in 2032. And I'm hoping that we're going to start seeing that we're helping prevent heart attacks, we're helping prevent strokes, we're helping prevent liver transplants with these medicines. And so the insurance companies will be able to adopt them better. That was certainly the case with like semaglutide in the Midwest. We saw that after the trial came out, we have a lot more insurance companies that are covering it. So hopefully that's going to pick up.
So, and there's a related question, one that even came in before this talk began, which was, will these drugs be bankrupting Medicaid, Medicare? So can you address that?
Yeah, at their current prices, there is certainly possibility for that, because something like 60% of people have an eligible criteria for an FDA approved utilization of this medicine. Like 60% of
Wow,
Americans.
that's
Um,
amazing.
and if you're talking about a medicine that costs $1,000 a month, $12,000 a year for 60% of Americans, like, yes, there's no way that that's going to be feasible. And what I've encouraged the Medicare and the state health insurance plans in Wisconsin to do is to look at the patients who need the medicine now, who are facing heart attacks and liver problems and bad pulmonary problems, things that I think are going to hurt them in the next 5 to 8 years, while I'm anticipating these medicines are still very expensive. And then thinking, like, it's not the way I medically want to think, but if I have to practice triage medicine, that other people who don't have consequences from obesity right now might be able to wait a little bit until we're able to
Cost down.
Exactly.
Yeah. So there's so many questions. Okay, so I want to get to the chat. I mean, I have questions too. So let's see, from Kim McElnay, are there any medical conditions besides medullary cancer with which these meds are contraindicated or which you would be concerned in using? That's a good question.
Yeah. So for people who have severe retinopathy, it's like a disease of blood vessel overgrowth in the eyes. That's something that should be like, you should have a plan with your ophthalmologist for monitoring that before starting the medication. It can be done safely, but it requires close monitoring. For people who have gastroparesis, where the gut already moves very slowly, the risk of these medicines is perhaps higher, because if we have something that's slow and we add an additional thing to slow it down, those people might have pretty severe consequences, terrible nausea, vomiting. I have done it with a statement of a patient saying, like, I need to try something. My blood sugars are completely under control or out of control. I can't do anything else. So we have tried it in that situation, just with the awareness that you could have a pretty rough week. And then when people have really bad kidney disease, these medicines haven't been studied very well. They haven't been studied as much in like stage 5 kidney disease or in dialysis states. We still use them, but we just kind of acknowledge with every patient, whatever your medical problem is, you might not have fit exactly into the population that was studied, and there might be some unknowns.
And how long does the medication stay in your body for?
So most of them, semaglutide, dulaglutide, tirzepatide, they are dosed weekly, and then liraglutide is dosed daily. So for somebody who's a little nervous about their first time, I've often used that medicine as a start, just to see how it affects them one time, or for one day.
Are there a lot of differences between the medications, the different forms?
So the liraglutide is less effective for blood sugar lowering and for weight loss. It typically induces about 8% weight loss and like 1% blood sugar lowering of A1C, whereas the semaglutide is about 15%, tirzepatide is about 20%. Dulaglutide is somewhere similar to liraglutide. So as new ones have come out, we've watched them get more and more effective for both blood sugar lowering and weight loss. And interestingly, the tirzepatide, the most recent one that came out, seems to perhaps have a little bit less incidence of nausea and vomiting. Same incidence of like diarrhea, constipation, abdominal pain, but a little bit less on the nausea. And they think that's because they added in an extra molecule to it. So that one is a GLP-1 and GIP agonist. And adding that GIP is maybe doing something to affect nausea.
Oh, interesting. So in terms of expected weight loss, and Rachel Butler's asked this, what's the typical weight loss, and is it different depending on how overweight or obese you are?
Yeah. I can't quote papers on this, but what I've seen in my patients is the people who have the most to lose the most and fastest. And so people who, and then I'm trying to remember exactly. I think it's people who have diabetes might lose a little bit less compared to the general population.
Interesting.
Yeah, I think that's right. I'm not positive. But people tend to lose weight over, like, most rapidly over the first 6 months on these medications, and then the weight loss tends to taper off, and they tend to have hit like a nadir around 12 months. This is
Mhm.
different from other previous anti-obesity medicines, where people typically lost for about 3 months. So we're seeing
Mhm.
people lose for longer, and then start to taper. But with any medication, we do see it like a plateau, because if you kept losing weight forever, you would die.
Mhm.
We don't
Yeah.
want that.
Right, right. And is there any like segments where these GLP ones don't work for weight loss?
Like, types of people.
Hmm.
There are, so tirzepatide, um, 93% of people lost at least 5% of their body weight. We
Hmm.
consider 5% the threshold where you are expected to have some improvements in some of your like metabolic health and
Hmm.
stuff like that. So we always shoot for people hoping to lose 5%. 93% of people on tirzepatide achieved that, but that means 7% of people didn't. So yeah, there are
Hmm.
there are people.
Hmm.
Sometimes it might be because some of those people weren't able to tolerate the medicine and didn't take
Hmm.
it.
Yeah.
But I've had people who were taking the medicine and felt like they weren't really losing very much weight.
Wow. Yeah, because it seems like you don't hear those stories very much, right?
Hmm.
Also, is it recommended to take a break from the medication to reboot kind of the efficacy? We see that in a lot of different medicines, like the anti-TNF antagonist and whatnot for some of the anti-inflammatory diseases.
That has been some of the colloquial reports, but
Hmm.
I don't think we have that checked in any kind of clinical trial at this point. We've seen that happen because of shortages of the medicine. You know, there's been a lot of periods of time where people aren't able to get their medicine.
Hmm.
Um, and overall, I don't think it's doing patients favors. My patients are telling me, when I don't have the medicine, I feel hungry, I feel terrible, I am eating more, I'm regaining weight, and we
Hmm.
start to see this yo-yo phenomenon. There was
Hmm.
actually a paper years ago. It's not perfect data, but it suggests that weight yo-yoing could be more dangerous to the heart than just having a high weight and maintaining it. So I tend to think that's not the direction we're going to recommend going with these medicines.
Hmm. And in prep for this presentation, we were talking a bit about some of the challenges of long-term medication and access and supply. So can you address that a little bit in terms of what people need to be watching out for and
Yeah, I mean, I can tell you what to watch out for, but I can't tell you how to avoid being a victim
fix it?
of
Yeah.
lack of supply.
Yeah.
Exactly.
Yeah.
So these medicines had just like tremendous amounts of uptake, lots and lots of social media spreading of, hey, you should get your doctor to put you on this. And I happen to agree. I think these are really wonderful drugs that can help a lot of people. But because of that, the company wasn't able to meet with the demand. They had purchased a factory that they were going to start manufacturing at, and then it was damaged by a natural disaster. They've ramped up production at several other places, and the reps just keep telling me, like, we're working on it, we're working on it. I think it's been better this year than it was in 2022 and 2023. But I think
Yeah.
we'll expect to still see shortages. Making a syringe involves a lot of work at a factory, or making like a pen involves a lot of work at a factory. And so people who know what they're talking about have really been encouraging the companies to start making these medications in vials. And
Yes.
tirzepatide actually just started shipping vials to the United States, although they're still single dose, which is kind of a waste. If we could get multiple doses in a vial, it would probably improve manufacturing. Is my sense of the situation. But there's a lot of desire for the companies to be able to retain control over how medicines are being dosed. So
Right, right. Um, so we had also talked about, I had seen an ad in like on the next door about like inexpensive GLP Ozempic. Can you address like how does that even happen? And is this like real medicine? And do you have to be wary about it?
yeah, so yeah, I was driving there was a cardboard sign attached to a light pole that said, like, need semaglutide, call here. Like, these things are they're everywhere. Um, but
Scary.
it's because of this legal loophole. So um, the pharmacies are able to get access to the raw material, like semaglutide, and they are able to compound it and put it into a fluid and give it to people in a vessel and inject or advise them on how to inject and stuff. I think one of the most dangerous things that I'm starting to perceive is the online companies that say, like, oh, come do a 30-minute visit with our doctor. You'll walk away with semaglutide. You never have follow up. Because people need to hear the things that I've just been telling you, and a lot of times people are going to have trouble with the GI side effects, require a little bit of going back on their dose, when to go back up on their dose. Um, what things are actual real credible threats? Did their family member actually have medullary thyroid carcinoma, or was it something else? And I don't think you can address that in the 30-minute visit. You certainly can't address whether somebody's going to be able to get good, adequate nutrition, and to talk to people about how to keep their body healthy while they're creating a calorie deficit. So I think the lack of knowledge that's accompanying a lot of this easy med use is one of the things that scares me. Another thing is that these raw materials being compounded is not regulated by the FDA. You don't know if there could be something else that's compounded along with it. And the companies, to me, that are like trying to make a quick buck, I wonder if they're cutting corners in other ways, if there could be safety concerns. Um, the third thing that scares me is that people might suddenly lose access to these medicines, because as soon as the brand name semaglutide is back off of the shortage list, then they're expecting that the big companies are going to shut down these little compounders, and then all of a sudden you were getting your medicine for $150 a month before, and now the price tag goes up to what the manufacturer is charging, and you can't afford it anymore. Well, now, okay, you've lost weight, you can't afford to take the medicine anymore, and we know from that data that you're just expected to go back up. And that's not any comment on you or your mental fortitude, or how much you're trying. It's just a fact. And so I worry about people who are doing so well on the medicine, when they get it taken away, what is that going to cause?
Do we have any research on people who have, I mean, I know that the clinical studies in general that were from the manufacturers said that people always regain weight, and we have anecdotal information about people who've been able to get off and maintain their weight loss. So are there any I don't know, strategies that would help people be able to get off or lower their dose over time?
I've had remarkably few patients who have been able to maintain a weight loss after stopping one of these medicines. I think I can count one patient after losing, and so it's not something I'm seeing frequently.
Yeah.
I have had patients who are trying to figure out the most affordable way to continue these medicines, who have been taking the medicines every 10 days instead of every 7, who have been with some of the pens, you're able to like inject a smaller dose. And so trying to see, okay, I'm going to give myself a smaller dose and see if that can help suppress my hunger. The way I tell patients to help identify if is this strategy working is to be really in touch with hunger. I have people keeping hunger diaries, because that is my biggest predictor that somebody is going to experience weight regain.
And Deborah Everson asks, the expectation is that once someone starts these meds that they stay on them for life. Yes, that is the expectation. I guess one of the things that I'm kind of curious about that we've seen in some of the other injectable medicines for other diseases is that over time they stop working. And so a lot of people switch over to a different brand or different, formulation. So do you see people switching between the brands to either maintain or increase their weight loss or continue their access?
Um, I haven't seen like the idea of tachyphylaxis that your body gets used to the medicine and you uh, that you start to have
Yeah,
weight
stop
regain.
responding. Yeah.
Yeah.
Hmm.
So one thing that actually is pretty common is that patients will tell me, I don't think the medicine is working as well. I'm
Hmm.
feeling more hungry. I'm feeling more aware of food. But
Hmm.
when we actually look at their weight pattern, they are still maintaining weight. So that's really interesting to me. And I don't know, but
Hmm.
that I've definitely seen. As newer and newer medications have come out, I've had a lot of patients switch either for a desire for something with more efficacy. They jump up to the next one that has more weight loss associated in large trials. And so that's a common reason for people to switch. We have new medicines in the pipeline. There are probably 3 that will come out in the next 3 years. And so I anticipate people will continue to switch up. Um, and then
And
a
what are
lot of,
those three? Yeah. Yeah. I'll go ahead and send you the follow-up after you complete. Sorry. Yeah.
well, that's it. So the two that I can think of off the top of my head, one is called retatrutide, and one is called cagracellin. Those are two that I know of that are in the pipeline. So we'll have to continue to wait on those.
And are they different? Or are they improving like the one that decreased the nausea and side effects? They slightly
Yeah.
altered. Yeah. So,
So retatrutide is going to have the same things, the GLP-1 and the GIP, and it's going to have a third agonist of glucagon. So it's like figuring out, can we do one other thing to help um, with sugar metabolism?
mhm.
Um, the cagracellin is I believe cagrasema. Cagrasema. It's semaglutide combined with an amylin analog. Um,
Mhm.
and so that's it's like kind of building off the same platform and adding in extra
Mhm.
molecules to see if we can get better.
Mhm.
um,
Mhm.
so and then the other thing I see is people often have to switch because of insurance coverage or availability. That's been really common.
Mm.
uh,
Mm.
and and I pretty much predict that if you have to go from semaglutide to dulaglutide, you're likely to have a little worsening of blood sugar, maybe be a little bit of weight regain. Whereas if you go the opposite way, you're likely
Mm.
to lose a little bit more weight. It doesn't happen for everybody, but the way that the large trials went kind of predicts the way that people tend to respond.
Interesting. Wow. So, I was going to ask you, well, let's hop back to, so I'm really focused on this hypothalamus idea. And when we were just right before we went live on this call today, we were talking about how the hypothalamus, controls a lot of different things, addiction, eating patterns, that kind of thing. And so, can you talk a little bit about what we've seen so far and some of these other potential applications?
Yeah, so it's been like a happy accident that some patients start on these medicines and then come back and they're like, hey, guess what? I'm not interested in smoking anymore. That's happened to more than one of my patients. Other patients, actually, I would say a significant number of my patients say that they're no longer interested in consuming alcohol. And there's a lot of research now being done at whether these medicines can help tamp down on those desires, those signals that are saying like, I need this substance.
Hmm.
Um, and so there are no FDA indications for those other habit forming substances, but I think that in time we're going to see more and more of that.
Does does it also affect other, areas of your life, like interest in sex or like, compulsive shopping? Or I'm just thinking like that whole idea of, you know, things that we think are really in our brain and executive function, but really are part of the lizard brain. I think that's
Yeah,
such an interesting idea.
I really wonder. I don't know that my patients would just voluntarily share with me information about interest in sex, but they often do. I treat
Hmm.
low
Hmm.
testosterone and things like that. I haven't heard reports about that. Um, compulsive behaviors. I do remember reading one case report about gambling. That
Mm-hmm.
somebody's compulsive gambling seemed to resolve when they started on
Hmm.
semaglutide.
Hmm.
So. Time will
So
tell.
interesting. I
Yeah.
know, I know. Well, and we were talking also about like anorexia or eating disorders and that whole idea of doing that really gets tamped down with these drugs, which is really pretty interesting.
Dr.
So,
Pavich, I have a question about tool two, actually, what the lab requirements are, because especially for patients who have access issues, is it something that is challenging for them, like the cost or the transportation, or what is required? Um, and then I have another question, which is just how much you see patients come in because of marketing on TV and social media and ask for specific drugs. I'm just fascinated by that whole process, but
It is fascinating. So I don't routinely measure labs unless a patient has diabetes and I'm following their A1C. I like to know somebody's kidney function, their creatinine level before starting this medication. But otherwise, there's not a need for routine lab monitoring. The biggest barrier to patients is the cost of the medicines. So that's enough of a big barrier in itself. Um, I just listened to a production from University of Colorado Internal Medicine where they were looking at how much of the drive for Ozempic has come from the direct to consumer advertising. So we're actually one of two countries in the world that allows direct to consumer advertising, and it has had a profound impact on medication use in the United States. And this time, a big thing that happened was the social media spread of these medications, which is really, really unregulated. Like, I don't think we even know how to regulate social media spread, and particularly with stories of like an N of one, this happened to one person, it gets spread. People don't understand the need for review of large trials and then individualization by a physician. But it's bringing people into the medical setting, and it's giving an opportunity for a conversation with a provider, and I think that could be a good thing. Um, what most people don't know is, regardless of what they saw on TV, what medicine they might be able to end up with is going to be determined by their insurance company. So it almost doesn't matter if you saw the commercial for Ozempic. If your insurance company will cover Trulicity, you're probably going to take it.
hmm. And different insurance companies are covering different
Correct.
formulations.
Mm-hmm.
Okay. And why is that?
I think price negotiation. I think the insurance companies negotiate directly with the manufacturer.
Wow. Fascinating. Fascinating. Um,
does
so
Medicare cover one of the, yeah.
So most Medicare plans generally will cover at least one GLP-1 for diabetes. So like you can pretty much always get one for diabetes. For obesity, up until March, the Medicare was not covering this, and we had been advocating under the Treat and Reduce Obesity Act, moving forward, kind of at a standstill for several years.
Mhm.
And then the SELECT trial came out. And so now most Medicare plans will cover um, Wegovy, specifically semaglutide for weight loss for people
Mhm.
who have a history of cardiovascular disease because of that secondary prevention.
Mhm. Thank you.
So Michael Wood, who is very well steeped from the nutritional area and effect on bodies, says that he has a diabetic friend who went on GLP-1 and said, "Great, now I can eat whatever I want," and ordered things, orange juice, grapes, really sugar, sugar, sugar. So how often does this occur? Like, does the hypothalamus impact what choices people are making also and what they're consuming from a nutritional perspective? And are you kind of messing your body up by giving it more and more sugar because you feel like you're free to choose whatever you want without consequence?
See, that's an interesting story. I don't hear that story very often. And for the patient who goes and orders all of that, they often tell me, and then I took 3 bites of it, and then I packed up the rest and brought it home. So there's a feeling of like I physically cannot put this spoon in my mouth because I don't
Wow.
want this food anymore.
Yeah.
Um, Patients often tell me that they have less interest in meat on these medicines. And then also less interest in what people describe as like snacky foods. They say like, like all those foods that I was going to because I just like was hungry in the middle of the afternoon. I don't need them because I'm not hungry at that time of day anymore.
So interesting. So Cindy Gatton asks, has there been any data on the use of these drugs on people that have already had bariatric surgery but gained a good bit back of their weight back?
I have a trial right now where we've written a grant to assess that. There is not a lot of data on it right now.
I know I have a family member who did have the bariatric surgery, and I asked her, because she's gained the weight back, I asked her if she would be a candidate, and she said no, because she's had all kinds of gut problems, from the surgery. So she said she wouldn't be a candidate, but maybe with these trials, it'll be a little bit more clear who's good and who's maybe not appropriate.
Mm-hmm.
That's great. So if anybody else has any other questions, to put them in the chat. And what I would say is, will we be seeing more clinical trials and applications, and what are the areas that you're most interested in exploring?
Well, so I actually am not as interested in treatment of obesity as I am in prevention. So like, I think these medicines are fantastic. I love using them. I love when patients come back and say like, I have my life back. It's such a satisfying area of medicine to practice. But I think where we then need to be focusing our next efforts is preventing obesity in the next generation, changing the way that we are raising children with food available everywhere. My kids' swim team is, I was told, oh, swim team is 90% about the candy and 10% about swimming. And I'm like, okay, we need to focus down. That's where we need to go next.
Yeah. Yeah. So somebody who had bariatric surgery 7 years ago, lost 150 pounds, and want to try Ozempic after post baby weight gain. Is that, in your experience, a use that would be possible?
If they meet criteria, so the the guidelines say for an anti-obesity medicine, body mass index higher than 27 with a comorbidity related to that extra body fat, or higher than 30, then I think it's possible. And then that would be a conversation about whether insurance is going to pay for it, and whether it's available, and then whether the treating clinician thinks that it's reasonable based on the patient's individual profile.
Great.
Is there
Great.
an age that there is a limitation on? Can
Um,
kids have?
I was actually just looking this up right before we started. I treat adults, so all of these medicines are available for adults, and I believe semaglutide is available for children. It might be 16. Let me just double check this.
Mhm.
That would make sense.
Be interesting to understand the impact in young people, because I think
Yes.
there's
Yeah,
so.
with developing organs and, yeah,
Mhm.
although like you said, it'd be better to prevent it than treat it.
It's like I've met some kids who already have really, really dangerous consequences from obesity. And so it's like if you're already experiencing a problem, then it makes sense to consider treating it. Whereas if we're trying to prevent a problem that could happen, maybe that
Mhm.
brings about the higher level of risk.
Mhm.
Yeah.
Um,
And I knew a friend's daughter. I'm just thinking about her, as we're talking about that. And she always described her daughter's hunger like she doesn't have an off button, which it seems like this is the drug that allows you to have an off button with hunger.
Correct.
Mhm.
And there are actually several known brain pathophysiologies that contribute to this. So there's several genetic mechanisms that cause
Mhm.
people to have an absence of satiety. Also, people who have had certain types of strokes or certain types of like brain tumors, specifically like a craniopharyngioma,
Mm.
those people often have an absence of satiety.
Mm.
Um, and yeah,
That's
where these
that's
medicines are being
interesting.
studied in those very specific pathophysiologies.
We're going to be having an X Center focused on trauma-informed care. And in my discussions with someone who is a survivor of childhood abuse, what she told me was that kids who are sexually abused actually have greater likelihood of having physiological issues. And I'm just wondering also if there's generation or other kind of trauma that leads to, the hypothalamus not performing in the way that it should be.
I think you're certainly onto something there. I think some of the worst stories I've heard of like things that have happened to people
Mm-hmm.
have happened to some of my patients talking to me for weight loss. And they,
Mm-hmm.
we go back into like what happened in childhood and how did that affect how you ate.
Mm-hmm.
It's amazing, and it's really really a kind of sad thing that's happened to some people.
Yeah, yeah, amazing. So as we're wrapping up here, anything else that we want to cover here? I just want to make sure I'm not missing anything in the chat. Says thank you so much. I informative. This person's from England and wanted more information as there's very limited info across the pond. So you're now officially helping globally. Thank you for that. And is there any other final comments before we wrap it up? Okay.
No, really, really interesting and helpful information for, I mean, both clinically for advocates, but for like friends and family people I know. It's very helpful. So thank you.
Thank you very, very, very much.
Yeah, thank you for having me. Have a great day.
It was really wonderful. Thank you.
Bye.
Okay, and we'll see everybody next month. Our topic will be disability insurance benefits and helping individuals get the benefits that they need. So,
And we have a case review on September 19th with
yep.
Melina. So yeah, look forward to seeing everybody.
Go to the website, check out our events. Okay, thanks everybody. Have a great Monday.